So the topic of discussion today is the metastatic neck disease. Now, this is a very important topic, whether from the point of view of your management, wherever you are practicing, and especially for you, the NB students, there will be lots and lots of questions, whether in theory or in practical or in your OSCEs. So these you need to know this topic in details. So we shall be covering as much as possible of this topic. Let's start off now. So introduction. So one of the most important prognostic factors in any head and neck cancer is the presence or absence of neck nodes, its level and the size of lymph nodes, and a number of factors control the natural history and spread of tumor based on this neck node involvement. The degree of lymph node involvement should be regarded as an indirect index of the systemic tumor burden. So lymph node involvement is an important index of systemic tumor burden, and elective removal of regional nodes serves as a staging procedure for treatment, surgical and non-surgical. Of course, elective removal of regional lymph nodes comes with its own controversies, and we shall go in it in details later on. Now, this is a very simple, you must have, even in your undergraduate days, you must have gone through this diagram. This is taken from the American Academy of Head and Neck Surgeons. It's a classification of the oncological classification of the cervical lymph nodes. So level 1 to 7. So level 1, I'll go through it in as fast because all of you must have gone through it. Level 1 is submental, submandibular. It is again divided by 1, 1B. We shall go into it in the next slide. Level 2, upper jugular lymph node, again divided into 2A and 2B. Then level 3, middle jugular lymph nodes. Level 4, lower jugular lymph nodes. Level 5, posterior triangle lymph nodes. Level 6, the anterior compartment lymph nodes. And at the end, level 7, superior mediastinal lymph nodes. Now, you will observe one thing, that there is a sort of a error because the retropharyngeal lymph nodes and the parapharyngeal lymph nodes are not taken into account in this classification. So this is a, you may say, a controversy or a fallacy in this classification, and that has been documented in the literature also. Now, I cannot go into the details. This is available in all textbooks, but still I'll run through this slide. This is the neck levels as defined by the American Academy of Otolaryngology. The diagram I showed you in the last slide. So submental triangle, the submandibular triangle, it is boundaries are the symphysis of mandible, the hyoid bone, and the lateral antebellum of the digastric. Left anterobelly of the digastric and right anterobelly of the. This is the submental triangle. This forms the 1A. Submandibular triangle is bounded by the body, superiorly by the body of the mandible, the posterior belly of the digastric, anteriorly by the anterobelly of the digastric, and posteriorly by the stylohyoid muscle. Now, if you see, there is a radiological boundary also. You need to know this also. I'm not going into the details, but just for your knowledge, the level 1A and 1 levels have been classified radiologically also. The boundaries have been classified radiologically also. So 2A, 2B, see, the thing is that the first is the hyoid, then is the cricoid, and then is the sternal notch. So based on these, the classification or the levels are there. So 2A upper jugular will be from the lower level of the bony margin of the jugular fossa. Inferiorly, it will be the hyoid bone. Anteriorly, the stylohyoid muscle. Posteriorly, the vertical plane defined by the accessory nerve. 2B, again, now the accessory nerve will be the dividing line between the 2A and 2B. Upper jugular would be superiorly by the lower level of the bony margin of the jugular fossa, inferiorly by the lower body of the hyoid bone, anteriorly by the vertical plane of the defined by the accessory nerve, and posteriorly is the SCM or the sternocleidomastoid. Then comes the mid jugular. Mid jugular basically is along the SCM from the hyoid to the inferior border of the anterior cricoid arch. I'm cutting a bit short for sake of time. Lower jugular is from the anterior lower border of the anterior cricoid arch up to the clavicle along the SCM. Then comes the level 5A. 5A is the triangle. 5 is the triangle that is bound by the sternocleidomastoid anteriorly, the uh, anterior border of the trapezius posteriorly, and the clavicle inferiorly. Now, this is again divided into 5A and 5B, depending upon the the division is by the posterior the sensory branches the posterior branches the how the course of the sensory branches of cervical plexus, and then comes the level 6, which are the nodes from the hyoid bone to the sternal notch and anterior posterior of the common carotid artery, medial and lateral. And superior mediastinum would be naturally in the superior mediastinum. Now, this is very important to know because when you are dealing with some malignancy of, say, a lip of the oral cavity of the oropharynx, you need to know where that organ is draining. So you would be careful while examining, and of course, your management, say your surgical excision, would depend upon the level of the lymph nodes that are draining that region. For example, level 1, are drained by the lip, the anterior tongue, the anterior floor of mouth, and the buccal mucosa. Level 2 and 3 drains the tonsil, the base of the tongue. Level 4 drains the hypopharynx and the larynx. Level 5, the nasopharynx, and level 6 is the thyroid and the subglottis. So as you see, as the organ goes down, the levels also go down. So just for the sake of remembrance, you may figure it out mentally in this manner. Now, coming to the details, the nasopharynx, the nasal cavities and the sinuses, they drain into 2, 3, and 5. Oropharynx similarly drains into 2, 3, and 4. Oral cavity, the posterior part drains into 2 and 3, and indirectly via level 1B. More anterior parts of the oral cavity and tongue also drain to these. More anterior parts of the oral cavity and tongue drain into the level 2, 3 plus level 1A or directly to the jugular node. Now the larynx, supraglottis, which is there is a high incidence of nodal metastasis, drained into the level 2 and 3. And there is a greater tendency for bilateral nodal drainage in supraglottic malignancy. Now, the vocal cord is basically a avascular structure, and consequently, a tumor which is restricted to the vocal cords would hardly ever metastasize to the lymph nodes. I think the documented incidence given in the literature for vocal cord neck nodal metastasis would be less than 4%. And hypopharynx, the drainage levels are 3, 4, 6, and 7. Now, occult nodal disease. Now, this is an important topic, especially for everyone, for your clinics from the clinical point of view also, and from your exam point of view. What is occult nodal disease? It is the presence of neck mets in the neck nodes that cannot be clinically or radiologically identified. See, there is some disease which is occult, which cannot be seen, and it cannot be seen either clinically or radiologically. And when you do a neck dissection, either by light microscopy or by some histological techniques like immunohistochemistry or step serial sectioning and molecular analysis only, you can find an occult nodal disease. Occult nodal disease can only be identified only when it is removed. So you cannot, if you have not done a neck dissection, so you cannot identify an occult metastasis. Why occult nodal disease is important? Because it is the starting point of the neck metastasis. So in various organs, in various malignancies, as you know, we tend to go in for a selective neck dissection where even if the neck nodes are negative, either clinically or radiologically, for the simple reason, in those cases where the incidence of nodal metastasis is high, say maybe more than 15%, in those cases, we assume that there is an occult nodal disease and we go for a selective neck dissection. And in many cases, you would find an occult nodal disease. Lymph node negative in a histology. What does it mean? That either the cancer has not reached the node or else it reached but was destroyed in the node, either by some immunological process or any other process. This makes several controversies in the management of occult neck disease. Observational data suggests that conversion of N0 to N plus is similar to the incidence of pathological positive nodes in elective neck dissection specimen. What does this mean? That if you do a selective neck dissection, you will find that in 30% of the cases, there will be a sort of a occult, you will find some sort of an occult disease. And this is almost similar to the incidence of an N0 neck if it is not treated, turning into a N plus neck, that is neck node positive neck. Now, there is a thing called cystic neck metastasis, though uncommon, but it is, you should know about this. This is usually of oropharyngeal origin, and its most common site being the tonsil of the tongue base. Actually, the human papilloma virus related tumors are more often associated because, see, a lymph node metastasis will always be a solid sort of a tumor. But a cystic would mean that either it is, would suggest rather, that it is either from the tonsil or the tongue base, and the human papilloma virus has been incriminated in a cystic neck metastasis. These lymph node metastases tend to have a better prognosis than a non-cystic or a solid counterpart. It was reported as a bronchogenic carcinoma in the past, and given the now we are finding more and more incidence of, or rather more and more detection of HPV positivity is there in oropharyngeal carcinoma throughout the world. Any cystic level 2 neck mass in an adult should be considered as a potential metastasis and should be investigated on those lines. I hope I'm clear. Now, what are the prognostic nodal features? That is, how does neck nodes, how will you prognosticate a disease based on the neck node features? The site of the neck node, the size and the number. Lower neck nodes are prognostically more bad. Extracapsular spread is bad. Morphology of the lymph node and bilateral or contralateral spread is again related with a bad, worse prognosis as compared to a unilateral or a single nodal metastasis. Now, this is the clinical staging after UICC. All of you should be knowing it. This is a must-to-know area. Here, I would like to point out that in the latest textbooks, earlier N3, first of all, let me start with NX. NX is when the lymph nodes cannot be assessed. Sorry, there's a typographical error. It is lymph nodes cannot be assessed. So N0 is no regional lymph node. N1 is single ipsilateral lymph node less than 3 centimeter. There is no extranodal extension is negative. N2A is single ipsilateral node based on within 3 to 6 centimeter in size. N2B is multiple 3 to 6 centimeter. N2C is bilateral or contralateral 3 to 6 centimeter in size. Now, this is a new addition, N3A and 3B. Earlier, if you find in the earlier Scots or Stelmarans, you would find that it was only classified N3. N3. So N3 was if the neck node is more than 6 centimeter, but now they are giving importance because there was a criticism that if there is an extra nodal spread, So that is not taken into account by this clinical staging. So they have now introduced an N3A and N3B. N3A is nodes which are greater than 6 centimeter, but no extra nodal extension. And N3B is nodes which are greater than 6 centimeter, but with a positive extra nodal extension. So this is a new addition. You should know this. So they now take into account the extranodal extension status and the HPV status and split the staging into distinct clinical and pathological classification. Now, factors implicated into the pattern of metastatic nodal disease. So what are the factors that will determine whether a disease is going to spread to the neck nodes or not? It is the tumor site, the size, the site. Some sites, for example, the oropharyngeal malignancy, tongue malignancy, or the nasopharyngeal malignancy, they are more prone for nodal metastasis. The tumor thickness, previous treatment, if any, and tumor recurrence. Tumor recurrence most often would present with a nodal metastasis. So, how do you assess a cervical lymphadenopathy? So, there's a case which walks in and you suspect that it is some sort of a aerodigestive tract malignancy. So, how do you assess it? First is after you have taken the history, first is the clinical assessment. After then, there are various modalities by which you can find out whether there is a cervical metastasis or not. So these are, I am listing them and then I shall go into a short details of each of them. Fine needle FNAC, ultrasound, computed tomogram, MRI, positive emission tomography. Nowadays, it is done in fusion with a CT. So it is a CT PET or a PET CT nowadays. And last not released, open biopsy, which has got very limited indications in a cervical lymphadenopathy assessment. Now coming to clinic, after you have had the history, you come for the clinical examination. So I need not go into the clinical details that you stand behind, you flex the head and all those things that is available in all your undergraduate books also. Now this remains the most important initial method of assessment. It is variable in accuracy. See, this is important because clinicians, suppose the first year or second year is showing it, he may miss some neck nodes, but still it is a very though it has got a variable it is variable in accuracy, but still it is an important tool for assessing a nodal metastasis. It has got a sensitivity of 74%, which is quite high, specificity of 81%, and an overall accuracy of 77%. Now, examining the neck, as you know, is difficult in short stopping necks. And drawback in nodes, drawback is that nodes may sometimes go unnoticed until they reach a considerable size. So there is a small node, it is say 1 centimeter, 1.5 centimeter, you may miss it. So that's why you see that the accuracy is only 77% and sensitivity 7. But each one of you should do the clinical, your starting point would be the clinical examination. Now, FNAC. This is the most important, I feel, technique and very easy, user-friendly. Only problem is that it depends upon the pathologist experience. Not every pathologist is experienced enough to catch malignancies in FNACs. But having said that, FNAC is one of the most important tools in diagnosing a nodal metastasis. Technique is particularly useful in the assessment of a palpable node when searching for a primary. In the presence of a primary, it is less useful. Now, why have we written that in the presence of a primary? Because you have already seen the primary, you have already taken a biopsy. So maybe FNAC, but rather a good clinical practice would be that even if you are taking biopsy from the primary, even then you should go in for an FNAC. That sort of counter checks your biopsy result. Suppose the biopsy has come negative from the primary. The biopsy specimen that you took was a superficial specimen. and in the FNAC, you get some squamous cell carcinoma, then you would be prompted to repeat a biopsy. But had you not done an FNAC and you just depended upon the biopsy result, you might have gone wrong and your decision making may have gone wrong. So it is an important tool that way also, that even if you have if you have identified the primary and you're taking a biopsy, even then you should go for an FNAC. It is easy to perform and quick in reporting, and overall accuracy rate of an FNAC is 90%, and that is not bad. Now next comes ultrasound. Of course, I would say not many people would be doing an ultrasound for a nodal metastasis. Nevertheless, it is important and it has been documented in literature, and it can detect the presence of malignant cervical lymph nodes with a sensitivity of 70 to 90%. When combined with FNAC, it increases 90%. You might have ordered in your OPD an ultrasound guided FNAC. That increases your sort of accuracy of diagnosis of FNAC. And there is no absolute criteria to differentiate between malignant versus benign on ultrasound. But there are certain indicators, like if the higher echoes are not there, there is increase in the short axis length. That is, it is a round sort of a structure or a body or a node. They are generally considered to be features of metastatic neck nodes. Now, CT is an important tool for your study for a nodal metastasis. It is important for detection of malignant neck nodes in higher than detection of malignant neck nodes is higher than clinical examination. And criteria, again, I will say it has changed. If you see the latest Scott Brown, they have changed the criteria. When we were students, the criteria was different. The criteria was that more than 1 centimeter in the nodes or more than 1.5 centimeter in the upper jugular-digastric nodes, and then round shape, and then central necrosis, and then enhanced rim. Now Scott Brown says that these are the criteria to categorize it as a metastatic neck node. That is the short axis diameter should be at least 1 centimeter, cluster of 3 or more nodes greater than 0.8 centimeter, and nodal necrosis or patchy enhancements within the nodes. This is the criteria for categorizing a neck node as malignant neck node on CT scan. MRI, again, MRI is meta-analysis that MRI can detect metastatic neck node disease. MRI is better than assessing angio neck in the presence of deep invasion. But generally, we would not order an MRI for the purpose of studying a neck node metastasis. Now, positron PET has recently come up in a large way, in a big way, and it has got a huge utility. So it uses 18-fluoro, 2-fluoro, 2-deoxy-D-glucose as radioactive tracer. You need to know the full name. Recently, there was a question in the OSCE, and many people did not do well in the OSCE. They could not name it, and they lost marks. So you should know the full name of this compound, which is used as the tracer for this investigation. It can identify the areas of high glucose uptake. You know the principle. It identifies the areas of the cancer cells, the metastatic cells will have a higher glucose uptake, and that is caught by the PET. And you can study. You can have a good, fair amount of idea whether that area has got some nodal mets or whether there is a cancerous area or something. So earlier PET was done solo, but nowadays we co-register the anatomical and functional imaging system, and a PET CT is done. It has got a role in the occult primary. Occult primary is where you cannot identify the primary, still there is a nodal metastasis. It has got a role in the recurrent disease, residual disease, and in distant metastasis. It has got a very high sensitivity and specificity, so it is an important tool for your study of nodal metastasis. Now, open biopsy has got a limited indication. In general, best avoided as initial diagnostic modality. When FNAC is not available, or it is non-diagnostic, or a result is suggesting a lymphoma. Lymphoma and anaplastic carcinoma are perhaps the only indications of open biopsy in cases of cancer or neck node metastasis. Prognosis will be different if the definitive treatment is done within 6 weeks, and any incision for the open biopsy you should ensure that that subsequently when you do a neck dissection, you can remove that scar while you are doing that neck dissection. Now, sentinel node biopsy. What is a sentinel node biopsy? Suppose there's an angio neck. It is used to assess the presence of occult disease in an angio neck. Assumption is that if these echelon nodes are negative for tumor deposit, the rest of the neck is free of tumor. So there are echelons. So when the tumor goes, the cancer goes to the neck, so there are first or second or third echelons of lymph nodes. So what happens is that you can use a radioactive probe or a blue dye, and you can inject it in the tumor, and you can identify whether the radioactivity is there in that part of the neck, or some blue dye has gone into that part of the neck. So if it is not there, that means you can easily assume that there is, at the present moment, there is no nodal metastasis. The nodes thus identified are then biopsied. If these nodes which are having this radioactivity due to the radioactive probes, or it has taken a blue dye, you will then biopsy it. And in head and neck tumor, there is a limited sort of a indication for a sentinel node biopsy, but the main indications are in melanoma, breast, and other non-head and neck tumors. Now, treatment of metastatic neck diseases. It is decided by the stage of the neck disease. Few points to remember. The untreated neck patterns of spread is predictable. See, what happens is that once you have violated the neck, some say that when you have gone through done a neck dissection, there is the neck nodes actually form a barrier to further spread of cancer. So the untreated neck pattern of spread is predictable because those barriers are there in place. In occult neck metastasis, it is usually found at first. The previous treatment alters, as I said, alters the pattern of spread because that barrier now is gone in a way. Now, coming to angio neck, we have already discussed the neck staging based on the UICC classification. We now discuss the angio neck. This is historically evaluation and treatment of angio is great dilemma and is still controversial. Whether to treat or not to treat is a big controversy even now. And there are a number of treatment options, that is elective surgery, elective radiotherapy, wait and watch, and elective neck investigations. So all these modalities have got their supporters, points and counterpoints. So these are all accepted treatment options for an angio neck. So how do you manage an angio neck if the incidence of the occult metastasis is greater than 10 to 15%? That is, so if there is the incidence of that tumor of metastasizing to neck is 10 to 15%. So if that is so, if that is yes, then it is primarily treated by radiation, or it is treated by a surgery. And if answer is no, then the patient is suitable for regular follow-up. Okay, so primarily treated by radiation, It is called the elective neck radiation and primarily treated by surgery. It is called a surgery selective neck dissection, in which only those nodes which are draining that area, for example, if it is the tongue, you will drain those, you will do the dissection of those nodes which drain the tongue. And this is known as selective neck dissection. So there are various forms of selective neck dissection. We shall come to it later on. So if the patient suitable for a regular follow-up, the answer is no. Then you consider elective treatment, because the patient may sooner or later may develop neck node metastasis, and there is no sense in taking the risk of leaving the neck untreated, even if it is an N0 neck at this stage. And if the patient can come for regular follow-up, then you go for a regular follow-up, then there is, you can keep on monitoring it. Now, indications of elective neck dissection, as I said, neck treatment is 15 to 20% chance of a subclinical neck disease. Vigilant follow-up is not possible, as I said in the algorithm in the last slide. Clinical evaluation of the neck is difficult, and access to neck for reconstruction. Now, suppose if you are doing a laryngectomy or any such a procedure in which you are going to anyway do a sort of a neck dissection, then you can combine a elective neck dissection along with this, and it is also an access to the to neck for reconstruction. Now, arguments which are in favor of going in for an elective neck dissection is high incidence of occurrence. The selective neck dissection has got a low morbidity and mortality. Routine follow-up will not detect the earliest conversion from N0 to N+. Neck node positive. Untreated neck mets can induce distant metastasis. We have to remember that. Elective neck surgery can be performed at primary surgery, and patient compliance for regular follow-ups cannot be assured. As I said, if the patient, you cannot follow up the patient, better to go for an elective neck dissection. And presence of multiple occurred neck will dictate adjuvant to the rehabilitation. Arguments against is that careful clinical follow-up combined with imaging has the potential to detect early conversion. So those who would say that don't go for an elective neck dissection would argue on these points. Control rates no lower than wait and watch policy is followed. The control rates by an elective neck dissection is no lower than wait and watch policy. Elective surgery results in inevitable morbidity. This is true. So this is to be considered. And an elective neck dissection removes the natural. As I said, that the neck nodes actually, in a way, they are forming some natural barriers to the spread of cancer to the body. So if you do an elective neck dissection, so that natural barrier is now gone. So some would argue that the distant spread would be more probable if we have gone in for an elective neck dissection. And it creates a scarred and hypoxia field and can reduce the radiation. If you're going for a radiation, the radiation field will be more. Now for an N1 neck, what do you do? Treatment modality is usually dictated by the treatment to the primary site, impalpable neck nodes. All the 5 lymph node levels should be dissected. Majority of the cases, X-ray nerve can be preserved. That is called an MRND. We will come to that later on. And many patients subsequently need a radiotherapy in a patient who have got a neck node positive. Now this is a algorithm of the N+ neck, primary and neck treated by surgery, and so you can go through this algorithm. I'll just switch on to the next slide because it has been explained in the next slide. Indications for post-operative radiotherapy. When would you go for a post-operative radiotherapy in case of a nodal mets? It is if there is an extra capsular spread, that is the N3C, to stay the TNM as per the TNM classification, 2 or more nodes positive, and 2 and 3 stages, and if there is a residual disease, as seen by your histopathology of the specimen, positive margins. And 2A and 2B neck. MRND sparing, it is a MRND sparing panel where possible, and 2C is common primary site is the tongue, base, supralarynx, and the supraglottic larynx, and the hypophyla. Earlier it was considered as a grave prognosis. Now evidence shows that the size, number, and the extracurriculars determine the prognosis rather than the laterality. So conservational neck surgery on less affected side and radical surgery on more affected side is the option. So this algorithm has been taken from the standard textbooks. And what are the N3 necks? These are the commonly fixed or skin fixed to the underlying structure or to the skin, and descent to operate or not decide by stage and primary site presence or absence of fixation. What the node is fixed. Now I come to the types of neck dissection. See, this is a related field, and you would be getting questions on this also. So you need to know this very thoroughly. So the neck dissections are radical neck dissection, modified radical neck dissection, a selective neck dissection, which are either supra or omohyoid or a posterolateral, lateral, or anterior, and an extended radical neck dissection. Now we shall discuss that in a bit of a details. So based on the 4 concepts, these are neck dissections are based on 4. That a radical neck dissection is the standard basic procedure for cervical lymphadenectomy, against which all other modifications have come in. Modifications of R&D include preservation of any of the non-lymphatic structures are referred as modified radical neck dissection. And any neck dissection that preserves one or more group or levels of lymph node is referred to as selective neck dissection. And an extended neck dissection refers to the removal of additional lymph node groups or non-lymphatic structures related to the R&D. These are the level 6 or 7 or retropharyngeal or the peripharyngeal nodes. Now, skin incisions, there are certain considerations for skin incisions when we are dealing with neck dissection. These are the respiration of the flap, the exposure, proper exposure of the field should be there, protection of major vessel, localization of the primary tumor. Consider previous radiotherapy and reconstruction, because then things becomes more difficult. Cosmetics and previous surgical field. Now, this diagram is very important. It has been taken from Stelmaran, and all standard textbooks have got it. Now, this is important because when you are planning your skin incision, so you should know how the blood enters and leaves the neck area. So blood enters from above or below, and from either side, the resultant watershed in the middle of the neck. So incision should be planned to utilize this so as to maximize the blood supply to the each of the neck flaps. So wherever you are giving the incision, wherever you are creating the neck flaps, it should be your endeavor to give the incision in areas where there is maximal blood supply. Now, these are the various standard incisions that are used. I will not go into the details. This is the Schobinger, then the horizontal T, the modified Schobinger, McPhee, the lateral utility, then Weiser, extended thyroid, H incision, Martin's, Hayes-Martin's incision, aprons, half aprons, onlay, Hatters, Weisers. So I will not go into the details because it is beyond the scope of my discussion today. So neck dissection, we can come to neck dissection. Let me give you a formal definition of what is a neck dissection, though we have discussed many things about neck dissection. It is an operation which removes the fibrofatty tissue containing the lymph node and all lymph-bearing structures, areas of the neck with or without the non-lymphatic structures. It may be with or without the non-lymphatic. What are these non-lymphatic structures? They are the sternocleidomastoid, the internal jugular vein, and the accessory nerve. Now, what is radical neck dissection? It will remove all the levels of lymph nodes from 1 to 5 and all the non-lymphatic structures. So the three non-lymphatic structures that I mentioned earlier, that was the accessory nerve, the IJV, and the sternocleidomastoid. So indication, it is extensive when there is an extensive cervical involvement or matted lymph node with gross extracapsular spread and invasion either into the spinal accessory nerve or IJV or the sternocleidomastoid. And what are the contraindication? Contraindication is untreatable primary tumor or unresectable neck disease. Patient is unfit for surgery, that is true for all surgeries. Distant metastasis. In case there is a distant metastasis, no use of going for a neck node metastasis. It's a very simple thing. And simultaneous bilateral dissection would be difficult. Now, I won't go into the details of the surgery because time would not allow me. Surgery, you can go through either still in the textbook, still Maran or this thing. I won't go into these. Now, then I come to the modified neck dissection. This is the Merinda classification. Modified, there are three types of modified radical neck dissection, type 1, 2, and 3. One in which only the 11th nerve is preserved, with the IJV and the SCM being sacrificed. Type 2 is in which the 11th and the IJV are preserved, and the SCM is sacrificed. And in type 3, it is also called the functional neck dissection, in which all the three non-lymphatic structures are sacrificed. Now, what is the indications of type 1? This is operable palpable neck disease, N1, 2A, 2B, not involving the accessory nerve, and N0 neck. So, accessory nerve, because we are sparing, so accessory nerve must not be involved. Okay. Type 2. Now I come to the selective neck dissection. Any type of cervical lymphadenectomy with preservation of one or more lymph node groups is called a selective neck dissection. So here what we are doing is that we are only addressing those group of lymph nodes which are the primary drainage site of that particular organ. So there are four types of selective neck dissection. They are supraomohyoid, posterolateral, lateral, and anterior neck dissection. So in supraomohyoid neck dissection, we would be taking out the levels 1 to 3. It is indicated in N0 neck, and mainly it is indicated for a CA of the tongue or the oral cavity or the lip. Next comes the posterolateral neck dissection. It is indicated here we are removing posterolateral, as the name signifies, 2, 3, 4, and 5. So it is indicated in cancers of the skin posterior to the tragus. Then comes the lateral. Lateral is one of the commonest selective neck dissections to be done. It removes the levels 2, 3, and 4, and it is generally indicated in CA larynx, oropharynx, and hypopharynx in a T2 to T4 where there is an N0 neck. As I said earlier, generally these selective neck dissections are done in the angio neck. Then there is the anterior neck dissection. So this is removal of the lymph node surrounding the viscera structure in the anterior aspect of the neck, level 6. So it is generally indicated in differentiated medullary CA thyroid, where we are combining it with a thyroidectomy. Extended radical neck dissection. Here, besides the 1 to 5 neck nodes, we are and the additional non-lymphatic structures, we are also removing certain other lymph nodes, which are the retropharyngeal, level 6, level 7, hypoglossal nerve, carotid artery, and skin of the neck. This is an extended radical neck dissection. Then complications of a neck dissection: general, local, anesthetic complications, postoperative atelectasis with basal collapse, pneumonia, ischemic heart disease, urinary retention, and DVT. And local complications would include hemorrhage, wound infection, carotid artery rupture, nerve injuries, Achilles leak, and pneumothorax, cerebral edema. Now, these are all very extensive topics. You should read it from a standard textbook. I cannot cover this in such a short time, but each one of them, these complications constitute some sort of theory questions for you in the final exam. Now I come to another important topic, that is a neck metastasis from an unknown primary. So you find a nodal metastasis in the neck, but when you investigate, when you clinically try to find out the primary, you don't get a primary anywhere in the aerodigestive tract. So it is also called the occult primary. So it is a presentation of metastatic neck lymphadenopathy without the development of a primary lesion within a subsequent or within a subsequent 5-year period. That is, matlab, आपका इसके अंदर you have found out today, but within 5 years there was no primary detected. So it would be called a unknown primary. And failure to identify the occult primary. Why does primary, this is an important, interesting question. Why does occult primary occur at all? See, it may be due to spontaneous regression of the primary tumor. You know that nowadays there is a theory of the immune system, the role of immunity in tumors. So that may be due to the immune response to the primary tumor, which has caused a regression of the primary tumor, or it may be due to an autoimmune destruction. You may not be able to see the primary. So metastatic carcinoma with no evidence of primary site after history taking, physical examination, radiological examination causes is called a occult primary or an unknown primary. Secondaries of the neck, less than 10% of all the secondaries in the neck. If you see the secondaries of the neck, at least 10% would be with an unknown primary, and most likely head and neck primary site would be a tonsil, base of tongue, and pyriform fossa, which are actually the sort of hidden areas for the. These are the areas which are the likely head and neck primary sites for a unknown primary. Now, what are the diagnostic steps? The history taking, physical examination, complete head and neck examination, ipsilateral otalgia with normal otoscopy, direct attention to the tongue base, tonsils, supraglottis, hypopharynx, and unilateral serous otitis media and nasopharyngeal examination. So history taking is, as you know, is the most important. Then physical examination would include a complete thorough head and neck examination. In this, you would be careful whether the patient is complaining of any otalgia with a normal otoscopy. If there is a normal otoscopy and there is an ipsilateral otalgia, then you would you would suspect some sort of a tumor, some sort of a cancer, which is causing this otalgia. And in this, you would also then direct your attention to the tongue-based tonsil, supraglottis, and the hypopharynx. A unilateral serous otitis media is an important indicator. Nasopharyngeal carcinoma is can present as a unilateral serous otitis media, or anything in the nasopharynx can come. So if there is a unilateral serous otitis media, you should be careful in an elderly person. And now, how do you start investigating a case of radiological of an unknown primary? So, as I said, history taking. After that, you would do, first of all, as I said in my earlier slide, you would first of all investigate, do all the endoscopies, the nasal endoscopy, the direct laryngoscopy, you can go in for a pan endoscopy. You would direct your attention to the tongue base, to the tonsil. And after you have gone through all this, you have not you have not been able to catch the primary. Then you would go in for a chest X-ray, an ultrasound, a CT scan or an MRI of the head and neck, FDG PET scan of the whole body, and a radionuclide scanning. How to manage it? So after you have not been able to localize anything, you would go for blind biopsies, direct laryngoscopy directed biopsies from the nasopharynx, from the tonsil, the base of the tongue, piriform fossa, and suspicious or abnormal mucosal areas. Because your maximum effort would be to identify the primary. So these are the areas from where you would suspect that the tumor has arisen. So you would be doing blind biopsies from these areas, which are the nasopharynx, tonsil. You can do a tonsillectomy even for that, and base of the tongue, piriform fossa, and any suspicious or abnormal mucosal area. Then an FNAC and an open biopsy or a core needle biopsy can be done from these areas, and FNAC is helpful in identifying an adenocarcinoma of the upper neck and lower neck to rule out the thyroid gland malignancy. Possible histology of a unknown or an occult primary is squamous cell carcinoma or poorly differentiated carcinoma. And sometimes adenocarcinoma in the neck, you should, if there is an adenocarcinoma in the neck, rule out the salivary gland or the thyroid or parathyroid tumor. The other possibilities are the lymphoma or the tuberculoma, or rarely the sarcoma. So what is the role of PET? PET is an important diagnostic tool for an unknown primary. It is recommended for detecting primary disease and for staging. It defines suspicious regions and lymph nodes for biopsy in head and neck region, as well as identify metastasis. FDG PET is in unknown primary is 88.3% sensitive and 74.9% specific and 78.8% accurate in detecting unknown primary. These are the figures for detecting unknown primaries. Now, role of ipsilateral tonsillectomy in an occult metastasis. It's ipsilateral tonsillectomy is suggested for patients with submandibular, subdigastric, midjugular nodes, as may be the site of primary disease in 25 to 25% patients. And pan endoscopy, the role of pan endoscopy is squamous cell carcinoma on FNAC of the neck node. Then we go in for a pan endoscopy and direct visualization of the nasopharynx, the oropharynx, hypopharynx, larynx, trachea, bronchial airway. So it should be a thorough examination. So what is the treatment of a squamous cell CA of an unknown primary in the head and neck region? It is basically a multidisciplinary team approach involving surgery, radiation, and chemotherapy. What is the treatment modalities? A limited neck dissection if there is no extracapsular extension, neck dissection or ipsilateral neck radiation, and nodal disease with extracapsular spread post-op radiation should be given. And pan mucosal irradiation, radiotherapy to the neck and nasal oropharynx, hypopharynx, except except when there is a strong suspicion that nasopharynx is the intimidating area, and nasopharynx may be omitted when disease is limited to lower nose, and treatment of both the sides if there is a pan-mucosal irradiation. Management of patients, I've gone into it. This is an algorithm. So this is all. This is the, so I end my lecture here. I have taken some associated topics also, which were important from the point of view of your clinical knowledge and especially from the exam point of view. So Navneet, this would be all. So if there are any questions.
Thank you, Dr. Dev. Trainees, you may type your questions in chat box.
I think we are almost at closing time now. Was I audible?
Yes, sir.
It's a huge topic. I have just run through the topic actually. No, your question is any criteria whether to go for RT or surgery. So RT or surgery for which area of the for which organ are you asking this question? For example, if it is a laryngeal carcinoma, a purely glottic carcinoma, and if there is no sort of cartilage involvement, if it is a limited disease, then you give the option to the patient whether he wants a surgery or radiotherapy. See, the thing is that if he is going for a surgery, there will be a morbidity. I'm talking of a glottic CA, just for the sake of an example. There will be a morbidity and the associated problems like aspiration and change of voice would be there. But if the patient goes for a radiotherapy, he conserves his larynx, he conserves his voice. Only problem is that if there is some sort of a cartilage involvement, then radiotherapy is not the option. And another thing is that if you are going in for a radiotherapy as a primary modality, and if tomorrow you have to go for a if there is a recurrence, and if you have to go for a treatment of the recurrence of the disease, then surgery becomes very difficult in a post-irradiated neck or in a post-irradiated organ. So you have not specified, Harjot Man, criteria to decide whether to go for RT or surgery. This is for which organ are you speaking? Which organ? For which organ? For which part? Are you speaking about for the larynx, for the supraglottis, for which part? The commonest, the commonest question you would find in your clinical practice is in the CA glottis. So CA glottis, some would say go for surgery, some would say go for radiotherapy. As an ENT surgeon, you would not like to go for radiotherapy because you are a surgeon, you would like to cut in a lighter way, and I'm telling you that. But if you look at it, and if the malignancy is manageable by radiotherapy, by all means, you should go in for that. But if there is a problem, say, as I said, if there is a cartilage involvement, or if there is a chance that there may be a recurrence of the disease later on, then better to go for a surgery as a primary modality of treatment.
I think no more questions, Dr. Divya. Thank you very much for the presentation, and
And
thank you very much, uh, trainees, for joining us.
thank you, Navneet. Thank you for conducting the webinar in such an excellent manner. And it was a pleasure speaking. Thank you so much.